Now, these new grading systems are available, as I said earlier, from ViraCore. And here is an example of a test a result that you would receive. I filled this out with a hypothetical patient. Let's say that the patient had stage 2 skin, less than 50% of a skin rash. They actually had a bilirubin of 2.2, so that would be stage 1 liver. There were no upper GI symptoms, so that's stage 0. And the patient had about 600 cc's of diarrhea a day, so that's stage 1. When you fill out this form, you will see that in the legend there's some help that defines what upper GI symptoms are, and a diarrhea episode is about 200 cc's per episode. So for this patient with stage 2 skin, stage 1 liver, stage 0 upper GI, and stage 1 lower GI, the Manhattan risk is high, with a day 28 response of 49% and a 6-month NRM of 36%. The Manhattan risk is high because of the stage 1 liver. But if you send biomarkers, and in this case, they would be Ann Arbor 3, so high risk, now the magic composite score is 3. So the response rate is only 30%, and the non-relapse mortality is 52%. So this patient is in trouble even at the beginning of the GVHD therapy. Now, here's a similar patient, but it's not exactly the same. This patient has stage 2 skin like before. This patient has a bilirubin of 1.7, so not that different from 2.2, but it actually is a stage 0. Upper GI is also stage 0. This patient actually had a little more diarrhea. It was at about 800 cc's a day, but that's still stage 1. For this patient, the Manhattan risk is intermediate, with a day 28 response of 63% and a 6-month NRM of 15%. But when the biomarkers were tested, they were only Ann Arbor 1. That's low risk. So the composite score is a magic composite score of 1 with an 80% response rate by day 28 and only 6% non-relapse mortality. So you can see how beneficial it is to send the serum for these biomarker tests, which can help guide therapy. So my recommendations for treatment and onset are as follows. Do not preemptively treat grade 1 GVHD. We've now looked at over 1,000 patients, and waiting until a patient becomes grade 2 or 3 does not impede any effectiveness of the treatment, and in fact reduces the risk of infectious mortality. At grade 2 to 4, if you send a patient for this test and the result comes back as an MCS1, you can use low-dose steroids, let's say 0.5 milligrams per kilogram, and then institute a rapid taper. I would monitor this patient every 2 weeks until there's a complete response. But if the patient is an MCS2 or 3, which is driven by high biomarkers, I would suggest using 2 agents as first-line therapy. This could be ruxolitinib in addition to steroids, or some other therapy with which you are familiar and comfortable. This patient who's at high risk, I would monitor weekly. That concludes the presentation. If you have any question about Ann Arbor scores or magic composite scores, please don't hesitate to contact me at james.ferrara@mssm.edu. Thank you.